across levels, different levels and settings of the health system. So basically, this is talking about how the health system is organized to deliver services in a coordinated manner. And then we also hear of integrated care. So with the integrated care, this is a coordinated and seamless provision of services across different providers, different levels of care, different sectors, so that the patient will receive a continuum, comprehensive, and person-centered care throughout their life course. So integrated care is rather speaking to the patient's experience, because we have organized the system in such a way that the patient now experiences that kind of continuous care in a coordinated manner. And so integration is one of the ways of optimizing the use of common laboratory, case management platforms, infrastructure to address many of these diseases. I hope there's some clarity in some of the definitions I've just spoken about. So just some context. So when you talk about neglected tropical diseases, or NTDs for short, these are a group of patient diseases of poverty that impose devastating human and social and economic burden on more than 1 billion people worldwide, predominantly in the tropics and subtropical areas, among the most vulnerable and marginalized populations. And over the years, the past few decades, yes, there has been some global progress. Now it's known that people needing treatment have even reduced by about 32%. And countries are making efforts to eliminate these diseases. So now we have about 57 countries having eliminated at least one of the diseases. So some examples are here. We have guinea worm, human African trypanosomiasis, trachoma, lymphatic filariasis, onchocerciasis, etc., etc. And we have countries that have been able to eliminate these diseases. And I'm sure Dr. Opare will let us know that in Ghana, we have eradicated guinea worm, we have eliminated trachoma, and we have also eliminated human African trypanosomiasis as a public health problem. Some countries like Niger recently was able to eliminate onchocerciasis. So we have other countries making the effort, to also eliminate some of these diseases. So the current roadmap that we have, which is 2021 to 2030, in addressing the numerous gaps and challenges in the control of NTDs, calls for a renewed momentum through proposed concrete actions for the delivery of interventions through integrated platforms, and thereby improving cost effectiveness, coverage, and geographical reach of the programs. So these are a summary of the diseases, a table showing the diseases which are under control, diseases which are earmarked for elimination, and then diseases that are earmarked for eradication. And those marked in red, with the red asterisks, are the ones that Ghana has been able to eliminate as a public health problem and also eradicate. So what is the rationale for integration? Firstly, there are commonalities among these diseases. When it comes to the mode of transmission, their clinical features, their management, mode of prevention, etc. Many of them share commonalities in these. So when it comes to transmission, we have many of them may be transmitted by a vector, which is an insect, or let's say mosquito, to even be precise. And the mode of transmission for those diseases will be like the same cycle of transmission. And then many of the diseases share common clinical features. So some of them, you might not be able to even distinguish between them because they are very, very similar, the clinical features. And the management for many of them are also similar. We have many of them that will need what we call the mass drug administration. These are called the preventive chemotherapy, neglected diseases. And then the prevention. For instance, those that are mosquito-borne or transmitted by mosquitoes, for instance, would be prevented through the use of bed nets, for instance. So diseases like lymphatic filariasis, malaria, dengue. So all those diseases that are transmitted by mosquitoes will benefit from the use of bed nets. And again, many of them are co-endemic. So in one particular area, we may have many of these, maybe 2 or more of these diseases in that same locality. And therefore, they can benefit from shared resources. And this will help improve efficiency and cost effectiveness. And again, persons affected by NTDs share common or similar challenges. These include mental health problems, because many of these diseases are disfiguring, leading to a lot of disability and all that. So persons really, many of these have mental health problems. And many of them suffer stigmatization and discrimination with a lot of socioeconomic constraints. They cannot work, effectively, and they become poorer. So it means this will lead to further decrease in the quality of their lives. The skin, for instance, is the first and most visible structure of the human body, both for the patient and even the healthcare personnel. And it becomes an entry point for diagnosis for many of these NTDs. And when any part of the skin, most part of the skin is affected, it is quite visible. So examination of the skin, for instance, can serve as an opportunity to identify multiple skin conditions in a single intervention. So maybe a single case search or single examination. And this will improve case detection in settings which are often characterized by fragile health systems. So grouping and packaging of diseases depend on their burden in the countries will facilitate, joint delivery of those interventions through a common platform. An example is malaria vaccine. It is being delivered through the EPI system, which is very, very effective. And then also for the mass drug administration, we could use the same mass drug administration to also search for hanging worms, for instance. That is guinea worm. And that could be part of our surveillance for guinea worm. Having eradicated it, we still need to strengthen surveillance, making sure that it is not reintroduced. We can also use the case searches through the MDs, can use the case searches for other NTDs, such as yours, other skin conditions. What are the types of integration? Mention is made of 3 main types, or let's say categories of integration. We have the functional integration. And so this one is the integration of the support and management systems that enable the health services to operate. So we have a health management information system, which is kind of integrated. It has, all the disease being reported on that. And the supply chain, the laboratories. So when we do integration with these systems, that one is functional. So management functions are what we are integrating. Then we have what we call the structural integration, where This one is more of an organizational or institutional alignment, or let's say reorganization. So this has to do with merging or alignment of programs or even departments or the governance structures, within the health system. So for instance, in Ghana, we have the NTDs program, but we have structured in such a way that all the preventive chemotherapies, NTDs go into one side, and then the case management also go on the other side. Some countries have, let's say, leprosy and TB forming within the same unit. So the unit that oversees leprosy is the same unit that oversees tuberculosis, for instance. So it depends on the country context. There can be some of these structural arrangements. And when it comes to WHO, for instance, now malaria has been merged with neglected tropical diseases, and the unit is called Tropical and Vector-Borne Diseases Unit. So all these are structural integration. Then when it comes to operational integration, here we are looking at the delivery of multiple services together at the point of care, or through coordinated program implementation. It could be community-based, it could be at the facility-based. And this is what I think we'll focus on in this particular presentation. So what pertains in Ghana, for instance, and I'm sure Dr. Pare will fill me in if I miss anything out. But in Ghana, as I said, the NTDs have been arranged into the PCNTDs. Those are the diseases that require preventive chemotherapy. And here we have 5 main diseases that are undergoing MDA in the country. Then the CMs, or the case management entities. This does not mean that for the PCs, there's no case management for them. There is also. But the only difference is that these ones do not go by mass drug administration. And for the case management, we are looking at integrated management. So for many of the skin entities are case management entities. And here Ghana is pursuing integrated management through the case finding, diagnosis, treatment, and it's currently piloting a kind of syndromic algorithm in some of the districts. And this might inform policy change later, looking at how at the very lower levels where there's no laboratory and the rest, there could be a simple algorithm to help health workers at that level to manage some of these conditions before, if they do not improve, they are referred for further care. And then also we have integrated coordination in Ghana. So all the diseases, the NTDs, are being coordinated through a single coordination committee, what they'll call the Intra-Country Coordination Committee. That's at the Ministry of Health. And then there's also collaboration with other programs. So now malaria program and the NTD program are working together. They came out with a work plan. So they have a joint work plan, and then they are doing some of the planning for some of the activities jointly. So at least in Ghana, as we can see, we have a lot of effort is being made towards integration of activities. Some other areas for integration are as follows. So we can have integration in the active case detection, so that when people go out into the communities to actively, find cases, it will not just be one disease that they are looking for. They could have guidance to help them pick as many of the disease that they can pick as possible. And I've already mentioned that the laboratory diagnosis and the rest, so that we strengthen our laboratories in such a way that it can pick many of the conditions, not just one condition. Knowing that Jamesa, for instance, Jamesa stain can pick not only malaria parasite, it can also pick other parasites like trypanosomes and stigmagotes and the rest, or leishmaniasis. And then can also pick some bacteria infection and even some fungal infections as well. So mass drug administration can also be well integrated, not just the administration, but even the planning, right through the treatment, the reporting, and then the social mobilization, so that people get to know information about not just one disease, going for their social mobilization, then the following day another disease will go, but we can have it in an integrated manner where information will now go down. And then I've already mentioned stigma reduction and human rights issues, because it's not just one disease that needs stigma reduction interventions. Almost all the diseases suffer stigmatization. And then procurement and supply chain management, this one, a system of getting all the diseases. So we have the last mile system in Ghana, and all the medicines for the disease can benefit from that. And also surgery, as much as possible, can have integrated surgery where clinicians trained for hydrocelectomy, for instance, could also be trained for grafting, skin grafting, and the rest, so that it will be kind of multi-scaled intervention. And then surveillance and data management. We have the DIMS, which is the National Reporting System, which even for Ghana now, many of the NTDs are being roped onto it. And likely next year, maybe all the 14 NTDs in Ghana most likely will be roped up onto the DIMS, the DHIMs too. And then we have the Global NTDs Annual Reporting Form. And this one collates the report from all the NTDs at a go. So this is already an integrated kind of reporting, which countries report. Training could be integrated so that maybe when preventive chemotherapy training is going on, then we can now have training for all the diseases that undergo the mass drug administration. And WASH is really quite cross-cutting for almost all the NTDs. And when it comes to community education, social and behavior change communication, I think I've already spoken to that. Then advocacy. We don't advocate for just one disease, but this is a group of diseases sharing the same testimony. So advocacy should be cross-cutting. Mental health, we have addressed it. And nutrition is also very cross-cutting and needed for almost all the conditions. Supervision, monitoring, evaluation can also be integrated. Then we talk about One Health collaboration, where the veterinary services can be, collaborated with, because some of the entities are also zoonotic. So here we need that collaboration with the veterinary department, for instance. And then the referral systems and rehabilitation. Rehabilitation will be needed for patients, Buruli ulcer patients, leprosy patients, and all that. So it's quite cross-cutting. So many of these areas are cross-cutting and can be broadened to include so many other diseases. School health programs, yes, we can have school health programs where we are distributing the nets to school children. We can also use the same platform to distribute deworming tablets to the school children. And then also, now we talk about cross-border activities where we improve, we strengthen surveillance. We can also talk about synchronization, where two countries can decide to undertake some of these community-based activities around the same time, so that if it is mass drug administration we are doing, our neighbor could also be doing the same at the same time, so that we don't get people, run across the borders and missing these interventions. So I mentioned the global and regional frameworks. There are so many frameworks and strategies for us. And many of these strategies, frameworks, they all virtually speak to integration. So for the NTD, we have the global NTD roadmap, and it mentions the need for integration. We have the framework on integrated people-centered health services. And this was a World Health Assembly resolution. This was in 2016. We have the Ending Disease in Africa strategy, which is a strategy of the AU, the African CDC, and this one also speaks to integration. We have the MD, Multiple Disease Elimination Strategy, which is being spearheaded by WHO and PAHO, which also promotes integrated system surveillance and all that. And we have the framework for integrated control, elimination, and eradication of tropical and vector-borne diseases. And this one also spearheading the need for integration. And we have the Global Vector Control Response Strategy. And this one is talking about the need for vector control, strengthening vector control as a cross-cutting activity. And then in the space of NTDs, we still have that strategic framework on integrated control and management of skin-related NTDs. That was also developed out of the global roadmap to actually guide countries on how to go about integration. And recently we have the World Health Assembly Resolution 78. This is on skin diseases, and it talks about the fact that skin diseases are now a global priority, and there's the need for integration of the management of the various skin diseases. So what are the objectives of some of these frameworks? This one I think I'll run through quickly. So it helps countries to adapt and implement integrated strategies based on their local endemicity and their local needs. It also helps countries, guides them in strengthening people-centered services and care, enhancing early detection and surveillance for NTDs, how to strengthen monitoring, evaluation, outcomes and impact of integrated strategies, also enhancing advocacy, coordination, national ownership, etc. And then also a unified strategy for active case detection and integrated management when it comes to the skin-related conditions. What are some of the enablers of integration? Some of the enablers, this is just a few. The list is not exhaustible. So we have strong leadership, management, and governance as a key enabler of integration. And we have also mentioned information systems when integrated. It's a key good enabler. Skilled and flexible health workforce. Here we are talking about the multi-skilled health force. If you have it, it's a good enabler. And then integrated and efficient supply systems we've mentioned. Sustainable financing, and then effective payment systems. So if payment systems are not very effective and we have reformed systems, the better. And then effective referral systems, community engagement, and strong partner coordination. However, there could be some challenges with integration. And key among these are just a few, to mention a few. Constraints with funding. If the conditions we want to, or the intervention we want to integrate do not have funding. None of them has any funding. It becomes a challenge. And then disjointed planning is one of the key challenges when it comes to integration. Non-flexible funding source. So some funders or funding partners would insist that maybe their funds can only be used for that. But really, these are trends that are changing. Many of the funding partners now are also all out for integration and leveraging of resources. Then health workers can be overwhelmed. Sometimes if there are so many on their hands, they become overwhelmed with the work. And then volunteer confusion. For those that are community-based, volunteers can become confused if they have to do so many interventions at the same time. You do this for that disease, you do this for that disease, they might become confused. And particularly if they are different ages and that kind of thing. And then sometimes the volunteer can be overworked, not the confusion, but then moving from house to house, doing the NTDs can also be quite tiring. So if they have so many on their plate, sometimes they tend to take some shortcuts. And with that, quality can be compromised. The other challenge is the complexities of training. Because if you need to train people on so many things, then you really have to have time. And the training has to be very, very intentional about how you go about the training to make sure that there's no confusion. So what are the components of a good integrated health service delivery? So for good integrated health service delivery, realize that stakeholders management is done very well, and all the parties understand and they align, even in the engagement. And then adequate funding, because there will be strategic allocation of the resources to drive the integration. So you do it judiciously and efficiently. And then technological connectivity, creation and the effective use of shared technological platforms like the DIMS. Now there are so many apps that we use for monitoring and the rest, and it can be used for several diseases, not just one. And then the rules, clarification of the function and the responsibilities, if they are spelled out clearly, it enhances, it's a good component of integrated health service delivery. Then the governance, steering committees, smooth coordinations across all stakeholders, and then the communication, systematic interaction, structured meetings, data sharing. And above all, everybody will understand that shared vision, values, goals, and there will also be trust. So what are some of the guidance for countries? I think the frameworks have already been mentioned. In addition to that, we also have programmatic guidelines and documents for each of the programs that can guide the countries and the programs. And above all, national policies are also very important. So there should be national policies that are based on the principle of universal health coverage, where no one is left behind. So universal health coverage is at the center, at the heart of the SDGs. So that picture here shows, in Ghana, we even have the roadmap for attaining universal health coverage. And this was drafted in 2020. And now there are so many documents speaking to the free primary healthcare and all that. And countries are being encouraged also to be innovative, come out with innovative approaches and strategies. For example, maybe MDAs could be meshed with the child health weeks and school net distribution, merging that with the women, etc., etc. These are just examples. So countries can be innovative and are being encouraged to be innovative when it comes to integration. And In conclusion, integration is a technical adjustment in all public health programs and is actually a key strategic shift to enhance efficiency. It also enhances country ownership and partner coordination. So as Ghana strives to achieve the global targets towards elimination of NTDs, integration will help in addressing the resource constraints, and here not just financial, but also human and financial, to ensure cost-effective health service delivery. So on that note, I acknowledge our offices, our African Regional Office and our headquarters got some of the materials from these areas. And thank you very much for listening.
Thank you very much, Dr. Owusu-Antwi, and we appreciate that very beautiful presentation. Indeed, integration is the current global strategy. Countries are being encouraged to integrate because opportunities do exist for integration. That's the only way we're going to be able to fight this scourge with the limited resources that we have in country. So thank you. I've checked the chat box. I don't see any questions for Dr. Owusu-Antwi yet. I don't know. Are there any burning questions for Dr. Owusu-Antwi? We can take one or two questions before we move on. I don't see any hands up and I don't see any questions in the chat box. Okay, you can feel free to put the questions in the chat box and we'll answer them as and when. Our next speaker is a distinguished consultant public health physician. He has played various roles within the Ghana Health Service and has also worked at WHO Afro previously. Currently, he serves as the program manager for neglected tropical diseases at the Ghana Health Service headquarters, where he works to coordinate the country response to this very wide spectrum of disorders classified as neglected tropical diseases. He's a fellow of the Ghana College of Physicians Public Health Faculty, and he also has a PhD in public health. Ladies and gentlemen, our next speaker is Dr. Joseph Kojolabi Opare, Program Manager, NTDs at Ghana Health Service. Dr. Opare, we are ready for you.
All right. So, good afternoon, good evening, and probably good morning, ladies and gentlemen. I present to you at this moment, breaking the cycle, the critical impact of WASH and NTD control and elimination in Ghana. Right. So we are going to examine the WASH NTD transmission nexus in Ghana, present Ghana-specific epidemiological and operational evidence, highlight integrated case studies and implementation models, discuss strategic challenges, financing and opportunities, identify actionable recommendations for integrated programming. So, ladies and gentlemen, let's talk about neglected tropical diseases. These are 21 diseases affecting tropical poor communities. Over 1 billion people are affected globally. In Ghana, we have 14 of these NTDs as of now. These NTDs present in every district nationwide. Unfortunately, these diseases cause disability, disfigurement, poverty, and stigma. And you can see some of the photos of the diseases on the slide. There are two groups of neglected tropical diseases. We have the PC-NTDs, that is preventive chemotherapy NTDs, and case management NTDs. With the PC-NTDs, as you know already, we have onchocerciasis, known as river blindness, schistosomiasis or bilharzia, soil-transmitted helminthiasis, trachoma, and lymphatic filariasis. Then for the case management, NTDs, we have guinea worm, rabies, human African trypanosomiasis, yaws, cutaneous leishmaniasis, snakebite envenomation, leprosy, Buruli ulcer, and so forth. So onchocerciasis, currently endemicity is at 149 districts in Ghana. Schisto is found everywhere in Ghana, as well as soil-transmitted helminthiasis. Trachoma has been eliminated already. Lymphatic filariasis, we have currently 3 districts affected. Now, let's look at the burden of neglected tropical diseases. And as I've mentioned already, let's move straight to the key wash-sensitive NTDs, and these include schistosomiasis, soil-transmitted helminthiasis, lymphatic filariasis, onchocerciasis, and trachoma. And the photos you see over here speak about these conditions. Now, Ghana validated for trachoma elimination in 2018. Ghana certified guinea worm free in 2015. Human African trypanosomiasis was eliminated as a public health problem in 2023. Lymphatic filariasis transmission has been interrupted in 114 districts in Ghana as of 2025. Onchocerciasis eliminated is also targeting elimination by 2030. That's onchocerciasis elimination. We are targeting elimination by 2030. Soil-transmitted helminths and schistosomiasis continue to require integrated interventions. So, why WASH matters for NTDs? And ladies and gentlemen, WASH simply stands for water, sanitation, and hygiene. When we talk about water here, our focus is on safe and clean water for drinking, cooking, and washing. Sanitation is all about proper toilets and safe disposal of human waste. Hygiene is about practices that keep people healthy, such as hand washing with soap. So in a nutshell, when we talk about WASH, it means providing clean water, proper toilets, and good hygiene practices to help people stay healthy and prevent diseases. So what is the connection here? WASH addresses environmental drivers of transmission of some neglected tropical diseases, prevents reinfection after mass drug administration, reduces disease burden and disability, improves health equity in underserved communities, support WHO NTD roadmap 2021 to 2030 goals, and strengthens sustainability of elimination gains. Now let's look at the transmission here, the WASH nexus, the connections, right? So when there is unsafe water contact, we are looking at schistosomiasis, open defecation and poor sanitation. We are looking at soil-transmitted helminthiasis, poor facial hygiene and water scarcity. We are looking at trachoma, poor drainage and vector breeding. We are looking at lymphatic filariasis, onchocerciasis as well. Then weak hygiene behavior may lead to persistent reinfection. Now let's look at schistosomiasis and water contact. Schistosomiasis of blood in urine or bilharzia is caused by Schistosoma hematobium and Schistosoma mansonia. These are the prevalent species in Ghana. There are others, but you hardly find them in Ghana. Transmission is through infested fresh water bodies, highly endemic along Volta Lake and other rivers in Ghana. Historically, prevalence reached 80 to 90% in some Volta basin communities in Ghana. So what are the WASH priorities here? Simple: safe water access, reduce exposure to infested water, environmental management, and sanitation improvement. You know, currently, female genital schistosomiasis has become a topical issue. Last year, there was a study in Ghana, and we found the prevalence of 27% in South district of the Greater Accra region, a prevalence of almost 17% in the Katsina Nankana West. We all know that female genital schistosomiasis is associated with pelvic pain, infertility, and HIV susceptibility. Highlights here needs to be integrated WASH and reproductive health approaches. Now let's look at the connection with soil-transmitted helminthiasis here. We know that transmission is linked to open defecation in contaminated soil, reinfection common in poor sanitation environments. School-age children are most affected. That is why the treatment has focused in this population, in this cohort. Integrated school SCH, schistosomiasis, STA, and soil-transmitted helminths, MDA, has been ongoing since 2010. But very soon, the connection with STH will be over because WHO is saying that the prevalence of worms, intestinal worms in Ghana is so low, below the threshold of not being public health a problem in Ghana. So what are the WASH priorities here? This is about community-led total sanitation, educating the community members to know the effects of open defecation so that when they are well-informed, they come out with solutions, getting better toilet facilities for themselves. Household latrines, hand washing with soap, school wash infrastructure, and so forth. Let's look at trachoma. It is a thing of the past now in Ghana. It has been eliminated as a public health issue. And trachoma has been strongly linked with poor face washing and inadequate water access. The strategy here has been the safe method strategy. And this is what is currently being implemented in Ghana after the elimination. The safe strategy involves surgery, antibiotics, facial cleanliness, environmental water improvement. And it must be noted that Ghana became the first sub-Saharan African country to eliminate trachoma in 2018. Then let's look at lymphatic filariasis and water management. We know LF is transmitted by what? The mosquito, the common mosquito that we know, basically the Anopheles mosquito in Ghana. There's connection with poor drainage and stagnant water support mosquito breeding, which we all know. Persistent transmission was had delayed elimination in 15 districts. So by now, we are okay. We've been able to do the elimination or interruption in 114 districts now, and we are almost there. We are just left with 3. In 2025, 114 districts stopped treatment after successful transmission assessment surveys. So what is the WASH connection here? It's all about drainage improvement, waste management, and environmental sanitation. Or with onchocerciasis, we are looking at black flies. We know that the flies breed in fast-flowing rivers. Ghana has 149 endemic districts. MDA continues in 86 districts as at 2025. And come next month, we are going to embark on onco, lymphatic filariasis, and schistosomiasis integrated MDA. So you are all invited, come on board and support the program. Vector control and environmental management remains what very important here. Riverine communities remain vulnerable due to occupation exposure. So WASH indicators and access gap, what are they now? According to the UNICEF WHO report 2000 to 2004, that is the joint monitoring report program, okay, global WASH, yeah. So over here, we have 59% of population has, we know that 59% of the population has access to basic sanitation. Only 43.5% have access to basic hygiene services. Rural hygiene access is 33.3%. Urban hygiene access is 52.8%. And there is persistent inequities, increased NTD vulnerability. Now, let's look at some evidence from Ghana. When it comes to the community-led total sanitation, we know that interventions associated with that has reduced soil-transmitted helminths burden so much. Water access improvement supported trachoma elimination. School-based deworming improved hygiene awareness, and of course, environmental management consistently implemented for soil-transmitted schistosomiasis has been supporting the elimination process. When it comes to the district health information management system, strengthening improvement, surveillance, and decision-making is also there. And when we have the system which we've been using continuously, we should be able to get the data and make informed choices and decisions from there. Now let's look at some case studies here. The super MDA model, what can be done? Integrated approaches, what can be done? If we have mass drug administration campaigns ongoing, at the same time with hygiene promotion, we distribute some soap, we do risk communication, community mobilization and volunteer engagement, then we are going to have higher uptake and improved community ownership. And we should be heading towards elimination of these neglected tropical diseases, especially the preventive chemotherapy ones. Let's look at another case study, wash and endemic communities. When we have borehole construction, community water systems, school and household latrines, hygiene behavior campaigns, partnership with district assemblies and NGOs, then the focus on high burden and unaccepted districts, then we should be getting rid of most of these NTDs as well. Can we involve behavioral change communication here? Yes, of course. SBCC has been identified as a critical enabler in the Ghana's health system. Community awareness, ownership improves sustainability, and the key messages here should focus on hand washing with soap, face washing, safe water use, latrine utilization, of course, and of course, media platforms and just improve outreach services on these issues as well. Then let's look at the CHIPS, the Community Health Planning Services here. The CHIPS compound supports integrated primary health care delivery and creates a platform for hygiene promotion, NTD surveillance, community engagement, follow-up care, and there is a strong opportunity for integrated WASH NTD messaging over here. Let's look at the health systems and the DIMS2, that is our registry. The DIMS2 District Health Information Management System supports NTD data collection and reporting, and this is a system we are all using in Ghana currently. New NTD indicators had been integrated into the DIMS platform. Last year, we had a whole lot, and we had to work with the PPME division to get these indicators into the DIMS. Over here, data-driven approaches improve LF elimination progress. Digital systems can support integrated WASH monitoring. But of course, we have some operational challenges. Siloed health and WASH financing is a big issue. Sustainability of WASH infrastructure. You manage to get a borehole for a school, latrine for a school, you go there in a year or two, you may not find the same condition. You may not find these structures working properly. Transportation barriers in rural endemic areas, workforce shortages and competing campaigns, low CDD, that is community drug distributors remuneration, urban MDA participation gaps. Big issue here. It's so difficult to work in the urban areas when we have to do MDAs. Let's look at equity and vulnerable communities. NTD disproportionately affect rural and poor communities. Feeder roads become inaccessible during rainy seasons. Hard to reach populations face reduced access to service. Gender dimensions improve for female genital schistosomiasis. It's important for female genital schistosomiasis and caregiving burdens. Financial and sustainability, financing and sustainability here. There's a huge funding gap for schistosomiasis and soil-transmitted hemanthiasis MDAs. Ghana is always looking for resources and also trying to mobilize some locally, which has been the focus now. We are also seeking to unlock reaching the last mile fund. Actually, this is what is sustaining the program now, supporting many activities on onchocerciasis and lymphatic filariasis. We definitely need to increase domestic financing. Long-term sustainability requires what? Joint wash and health planning. So we have to move together now. There are strategic opportunities here. The first one is about strong community health systems. We have them already. Existing school health platforms, we also have them. High mobile phone ownership supports digital SBCC, which is true. Intersectorial coordination mechanisms already exist, and donor interest integrated NTD program. This is the way forward now, and many donors are recommending this. When it comes to policy recommendations, we have to institutionalize joint wash and health planning and budgeting, expand targeted wash investments in endemic districts, integrate wash indicators into the NTD monitoring system, which is ongoing, increase operational research on reinfection and behavior change, and strengthen local government involvement. This is crucial. So looking at the future priorities for Ghana, is about sustaining trachoma post-elimination surveillance, which is currently ongoing, expand SCH, STH impact surveys, which we hope to get support to initiate this year as a continuation from what we started earlier. Improve urban MD participation, especially in Greater Accra. Some districts have the infection now. Strengthen environmental management and interventions. Enhance, of course, disability management and social protection for patients with lymphatic filariasis. So, ladies and gentlemen, what are the key messages here? WASH is foundational for sustainability or sustainable NTD elimination. We cannot take off or eliminate NTDs without looking at WASH issues. MD alone cannot break transmission cycles here. Community ownership and SBCC are essential. Ghana has demonstrated strong elimination progress. Multi-sectorial integration is critical for 2023 goals. So, ladies and gentlemen, I'm done for now. Thank you very much, and much acknowledgement goes to our Director General, Director Public Health, and all the health workers and community volunteers in the NTD fraternity. Thank you very much.
Thank you very much, Dr. Joseph Opare, for that very insightful presentation. Indeed, you've done justice to the topic. There are some hands up, and so Dr. Ernestina Nanwinkum, can we have your question? Ernestina, you have the floor. Please unmute and speak. Ernestina, you can unmute and speak. Otherwise, we would have Ebenezer Efichi. Ebenezer Efichi.
Thank you very much, Doc. Thank you, Prof.
Yeah.
Thank you very much, Dr. Opare, for the presentation. I'm Ebenezer Efichi from Kowa Franklins North, one of the endemic districts for schistosomiasis and onchocerciasis. There's something I want to find out how we can help our staff at the chiefs level, looking at terrains like Afram Plains, North and South, for them to distinguish between the schistosomiasis infection from probably other infections that the patients may present, so that we'll be able to diagnose properly at that end. And also to complement that, if we can have Quanta readily available always to these facilities, but not only during programs, so that they can have some of these medications to treat them, so that to help in breaking the cycle of transmission. Thank you very much.
Yeah. So thank you, Ebenezer, for the question. It's very simple here. When you have UTI, you can have blood in urine. When our ladies are menstruating also, there's also blood in urine, right? So the best thing to do here is to have a lab, okay, test the normal urine RE will come out whether there's any egg of the schistosome, okay, in the urine. Or when you can also do car-to-cars here, probably we may not get this at the CHIPS compound, but you could refer to the district hospital, right, for a lab test. And on the praziquantel, you see, the strategy is very simple here. After mass drug administration, the district health directorate is supposed to retain all open bottles of praziquantel at the health facilities. All unopened bottles are supposed to be sent to the regional medical stores. So this is what we've been preaching all the time. And because we give more than what is needed in the district for treatment, we should be fine with these. But if we still have some challenges, let us talk behind the scenes so that we could get some solution for this. Thank you very much.
Right. Thank you very much, Dr. Opare. And some questions in the chat box. Dr. Owusu-Entwi, Solomon Anaya wants your view. He asks, what's your recommendation for functional integration of NTDs in Ghana? Recommendation for functional integration of NTDs. Dr. Owusu-Entwi.
Yeah, thank you very much. I think I have actually responded to Solomon in the chat.
Yeah, chat box,
But
yes.
I mentioned something like the incorporating, the NTD indicators in the DHIS
Yes.
or the
Yeah.
DIMS2, which is already ongoing. So that is one of the very simple and key ones to do. And then also WASH. I think Dr. Opare has just spoken about that. And then also our SBCC, because we already have a system in place for social and behavioral change communication. And so that is also some of the functional, integrations that we could do. And then the supply chain of our medicines, we already have a system in place. Doing the last mile, we can always have this, the medicines incorporated. In fact, they are already, but they need to be strengthened. So as I speak, WHO is building capacity for us to really strengthen that in Ghana. And then self-care, wound care, wound management and all that. These are functional systems that we can always, integrate with our NTDs. There are a lot of them, so many of them. In fact, the list I gave, I said areas of integration. Many of them are functional. And some of them are just, some interventions, but some of them are also functional. Thank you.
All right. Thank you very much. And just something from me. How feasible, Dr. Owusu-Entwi, in your opinion, how feasible is it to train frontline health workers to enable further decentralization of care to the primary health care level at the CHIPS compound? Do you have any thoughts on that?
Yes. I think I even mentioned that with the skin NTDs, something like that is already going on. When it comes to training of the frontline health workers at that level, we really need to look at their context. Many of them do not have laboratory support. They don't have, guidance, expert guidance and the rest. So for them, we could develop very simple guidance, the form of things like algorithms, syndromic, kind of management, syndromic approach to help them in their management, a lot of educational materials, and some of the basic logistics, basic medicines and the rest. But as much as possible, we could also support them with some of the basic laboratory, diagnostics, like rapid test kits. Now we are getting many of these rapid test kits. Many of them are not just detecting one disease. And these ones are very simple to train and very easy to use for the health workers at that level.
Okay.
So we really need to sit down and we can really do a lot at that level. Since we are getting all these diagnostics coming up and all these supports, these new tools coming up, and it will be effective. Thank you.
All right. Thank you very much. And I believe that's our senior, Dr. Erasmus Agongo. You have the floor, Dr. Agongo.
Hello.
Yes, sir.
Good afternoon.
Good afternoon, sir.
It has been a brilliant presentation, and I'm very happy. I think the program is on course.
Right.
What I could add or recommend is that, in fact, the problems of NTDs hinges not even on the health sector, but more on the developmental sector. And the district assemblies are critical to this. And most of our programs tend to focus on all the efforts on the health sector. Meanwhile, those things that should be carried out by the local government, they don't see it as a priority. You mentioned the issue of roads, access. It is the private sector, the local government. The issue of socio-economic development, issues that deal with discrimination, and they have that responsibility. Currently, we are told assembly members are given allowances. What is their role in addressing these fundamental social canker in their communities? We have been told chiefs' allowances have been improved. What are they going to use this to leverage the improvement of the lives of their people? I think we should actually come up with a strong advocacy at all the levels to ensure that local government carry out their responsibility. Yes, health sector can deliver the service to them, but the mobilization is their responsibility. Improving the conditions is their responsibility. Improving the living conditions of those disadvantaged people is their responsibility. So I think that is that area that the health sector should
Yes, sir.
work on seriously. Thank you very much.
Thank you very much, our senior colleague, Dr. Erasmus Agongo, a distinguished public health physician. And I have noted the comments of Regional Director, Dr. Amukodie, on integration and mainstreaming as being essential in the fight ahead. Chris Amwa, I've noted your question on stigma and issues related to leprosy and traditional belief systems. Perhaps we'll take that. I know that the next speaker will shed some light on that. And so if after his talk, your question is not answered, we would let you have the floor and speak to it. Somebody is asking, are there drugs readily available for use? Dr. Pari, do you want to speak to that? Access to drugs.
Yeah, so we get our medicine for treatment for schistosomiasis from WHO, all right? And there's also an NGO called Good Neighbors that has been helping us, right? So these are the medicines we have. So for this year, we are waiting for our consignment, but there is a clause here. WHO is saying that show us where you have the money for MDA, then we shall give you the medicine. So this is what we are working towards, right?
Okay.
But for this year, we have 13 districts that we are leveraging MD. We are leveraging on the support for onchocerciasis and lymphatic filariasis, MDA, okay, to kind of treat these 13 districts. So that is what is going to happen for this year. But we hope towards the end of the year, we shall settle on something to get our consignment to treat the entire population. Thank you.
All right, brilliant. And I'm happy to note the presence of Dr. Kingsley Esiedu. Dr. Esiedu is in charge of one of the leading lights of our country, and he's worked extensively and provided support to us through his work as the WHO headquarters in Geneva. KB, I don't know if you have a comment on this issue of access to drugs. I've let you talk, Dr. Seydo, if you have a comment on that.
Thank you very much, Yao, and all the organizers and speakers at this forum. Yes, access to drugs, I think, gradually also becoming more accessible in some countries, but also with some conditions that Dr. Pari also mentioned. In addition, as some countries also transition from low income to upper middle income or lower middle income, they also get away from this generous global support that countries receive. So Ghana may be also in that peculiar situation where at some point in time they may not be eligible for some of these donations, and this can also be a challenge. But at least for now, we will continue to support the country.
Thank you very much, Dr. Seydo, for that input. As we'll take, Abigail will take your question after the next presentation. Dr. Amukode, I believe we should move away from perennial drilling of boreholes that dry up in 3 to 4 years and get even infected at times. We note that, Abigail, I note your presentation. There are many more comments. We'll take several of those after the next talk. So our next speaker is health economist. He did economics, but instead of going to work at the World Bank, he generously dedicated his time to health economics, and working with him, I must say, is enjoyable. He's a brilliant scholar, and he's really one of the persons leading our understanding of the economic issues as they related to neglected tropical diseases. So Dr. Jacob Novinho is a senior lecturer at the University of Ghana. He works at the Center for Social Policy Studies, and previously he was at the Department of Economics at KNUST, and I'm happy to call him a friend. Dr. Novinho, we are ready for you, and you have the floor.
Thank you. Thank you so much for the very generous introduction, Prof. Amwaku. And many thanks to all our participants. Good afternoon, good evening, good morning, wherever you may be. I'll be speaking on the socioeconomic perspectives and the human phase of NTDs in Ghana. I think one of our last speakers, Dr. Agongo, actually set the pace for my presentation. So many thanks to him. So we want to just basically try and move beyond the clinic and see other perspectives to trying to understand the burden of NTDs in our country. So I'll just basically, in terms of outline, I'll move through the poverty NTD trap, something that my previous speakers have already highlighted. I'll just sort of give some contextual explanations to that. We'll look at the policy implementation gap in terms of financing NTDs and the economic and social burden of NTDs. We'll see some previous evidence, including some work we have done at KCCR on the economic burden of NTDs, as well as stigma and gender-related issues. And then we'd finally try to understand the coping and resilience strategies that households have used previously, and then make an economic call to investors to see NTDs not as another expenditure item, but rather an investment that could have significant returns if we do it the right way. So the poverty and inequality nexus or link that we established for NTDs, we need to see it basically not simply as an infection, But then the fact that it shapes and is also shaped by several factors that exist outside the hospital setting or outside the health sector. Chief key amongst those is deprivation. And I would use this simple framework to sort of expand on the points on poverty and NTD nexus. So we've all heard our previous speakers mentioned that it's a poverty disease, which means that basically households that are poor or vulnerable, they have great limitations when it comes to wash, and therefore exposes them to experiencing these NTDs. Now, when they are exposed to these NTDs, there are two things that happen. First, just the fact that they are exposed places economic and social burden. So if this person, for example, is a breadwinner in the household, suddenly that has a major impact on the household's income and consequently affects the broader household's livelihood and economic outcomes. The second economic burden that this brings is on the care-seeking decisions. So aside the fact that the household is already struggling to make ends meet, they also have to make decisions about seeking care, and that comes with costs. So that's the second phase of the economic burden. So that's like a three-phase burden. There's the clinical burden that comes with the pain and all of that. There's the economic burden that comes with simply experiencing the condition and not being able to undertake your regular economic activities. And then the third burden, which is now having to incur some costs when it comes to seeking care. What then happens is that ultimately the households either delay care or forgo care altogether. And that's where the cycle starts. So once the care is delayed, the condition is worsened. So eventually we see that the individual probably cannot walk properly anymore. And in terms of NTDs, we know time is of the essence. Time is critical. So the further the delays, the further the worsening conditions, and that exacerbates the economic burden even more. So the more you delay, the more money you would need for the treatment, the more productivity losses you face, the worsening livelihood conditions, and that pushes the household further into poverty risk, which eventually results in either the household becoming more vulnerable, becoming poor if they were not poor before, or moving even deeper into poverty if they were already poor. So that's how the cycle starts. And this poverty and deeper poverty or vulnerability exposes them to more wash limitations or challenges, and then the cycle starts all over again. So when we say that NTDs are a poverty disease, this is exactly what we talk about, and that sort of also highlights the need for interventions that would address these issues that go beyond the health sector to address poverty, to improve access and make life more comfortable. And if you look at even the households experiencing these conditions as well, there is a broader contextual arrangements that go with that. So I think one of the participants asked about the contextual issues. So the contextual issues, including the local epidemiology, the beliefs within the community, the availability of care and the effectiveness of this care sort of shapes the burden of the condition. So the mental health bed, the situation, the physical health, the social engagement, the economic well-being, and also shapes how care is sought. So whether the person goes through the formal healthcare system or prefers to go to a traditional healer, all of that is shaped by the context in which the individual lives in, which then in turn shapes the economic impacts, productivity losses, and financial costs, and then moves on to what coping strategies that are available to the individual. All of that, we can trace it back to the contextual factor. So the fact that this is a broader developmental issue, a societal issue beyond the health sector, is something that holds true in this instance. So what I want to do next is also to contextualize the whole analysis in the policy space. I think our first speaker clearly highlighted a number of strategies and policies that previously have been rolled out from the global level to the regional level to the national level. Policies do exist. I think our biggest question really is whether or not the implementation of these policies are done the right way, and where has that left us. So I've looked at two of these policies. Obviously, within the Ghanaian context, there could be more. The first one is the UHC roadmap that Dr. Entry mentioned in the first presentation, and then the now defunct NTD roadmap that was also mentioned earlier. If you put these two policies together, they highlight three of the most important components of NTD treatments and elimination strategies. The first one is WASH, which we have heard about. So both the UHC roadmap and the NTD roadmap highlight the need for increasing WASH availability or access to WASH infrastructure. The second one is PHT, which enhances the integration issues that we've been mentioning. So if we really want to integrate, it has to start from primary healthcare levels. This is where we can detect, we can do early detection, we can have community systems working effectively to help us eliminate these disease conditions. And then the role of communities. The role of communities are central to surveillance and treatments. These three issues are mentioned across the two policies that I have mentioned in here. And I'm sure many other policies that speak to health in the country would certainly have mentioned these three issues. The question, however, is how far have we gone in implementing these things and achieving the targets that we set for ourselves? So, for example, the recent harmonized health facility assessment that was conducted highlighted that there are actually very major gaps when it comes to NTD service availability and readiness, even though we have policies that sort of hold these things up. So, I mean, for example, we see that only about 25% of facilities offer any NTD service nationally. So the country, across the whole country, 25% of facilities offer some kind of NTD services. And 1% of these facilities offer specific NTD diagnostics beyond urine and stool tests. 17% support NTD services outside facilities. So community outreach and all of those other services outside the facilities. Only 17% of facilities supports this. And to highlight the equity issues that even emerge from these striking data is that 81% of these services are available at regional facilities, and only 4% are available at district level facilities. And if you think about the fact that the poorer people or vulnerable people who are more exposed to these NCDs actually have almost all the time their first contact with lower level facilities at the district or lower levels, and that has only 4% of service availability for NCDs. That's a major equity concern that as stakeholders we should be worried about. And then when you think about financing and further service availability, rehabilitation is like central to a lot of the NTD conditions that we are discussing this morning. And the National Health Accounts of 2022, if you look at it, just suggests that for rehabilitation services, about 0.25% of current health expenditure was spent on rehabilitation services. And that, coupled with the fact that only 5% of rehabilitation services are available in health facilities nationwide. And in these 5%, only 6% actually are ready for service. So only 6% of the facilities that provide rehabilitation services have the necessary tracer items available to provide care. So this puts the context in terms of the gap that exists and how much work and investment is still required to address the economic and social consequences of experiencing NTD, and also efforts to completely eliminate these issues. Now, if we shift focus to the individual level, providing financial access and financial protection. So if we went beyond the system to the demand side to understand what happens. We know that when we speak of UHC in our country, certainly health insurance, the National Health Insurance Scheme comes up as a major tool to achieving universal health coverage. But it's about time that we also start thinking about effective access or effective coverage, not just coverage. So for instance, currently we have close to about 70% coverage of our national health insurance scheme. But then if you think of the fact that service is available in only 25%, then there's always that raises a question about whether this coverage is actually effective. So if we give people health insurance cards and we make sure that their cards are active, would they actually get the care when the need arises and go
from
there
1 to
to
10.
get the care?
Choose number B.
Okay.
A chair
And then
down the way it's here. Maybe you 0 chair say in New York. 1 chair so area crab.
and then we have
Sir, please mute.
10.
Let me find the person, Jacob. Sorry.
yeah,
Can you
that's it.
mute? Thank you. Jacob, proceed.
Right. And then we have the PHC orientation, where we say that we want integration, and that should be done from the very lowest level so we can have better access to communities, detect cases earlier and treat, including outreach services that exist. And then we have indirect costs, the hidden costs beyond the health insurance coverage, beyond the direct cost that health insurance provides. And I think Dr. Agogo, when he was speaking, mentioned roads that would enhance access to healthcare when the need arises, transportation cost, food and accommodation, caregiving time that is lost, and all of that. So these are hidden costs that we have not really focused on or emphasized. And later on, I'll give evidence on the fact that this is a great burden on households from the work that we have done previously on NTDs. So then now I'll shift to the household economic burden for NTDs. What do households usually pay for? How much burden is that generating for households, and how are they coping with this burden? Okay, so household economic burden of NTDs in Ghana is really a significant factor. Some studies that have been conducted in Ghana suggest that on average, the mean costs, for example, for treating Buruli ulcer in Ghana is around $521. And the annual household cost in a particular district is captured around $35,000. More than 80% of the annual income is spent on seeking care in some of these poor and vulnerable households. That's a major issue if we talk about universal health coverage. And then if you look at the indirect cost that I mentioned, the labor time that is lost for affected patients, that accumulates to about 1 year in terms of labor time that is lost on average. And the costs we are talking about include direct cost of seeking healthcare, including transportation, wound care, food, clinic visits, and informal payments. Indirect costs that include lost work days, labor productivity, and caregiver time. Human capital issues that include school lost time and reduction in future productivity, and the fact that these households sometimes have to engage in distressful coping strategies that even worsens their economic conditions further. And these are some responses from some of the recent work that we have done in KCCR on the economic burden of NTDs. So this study, for example, in 2024, there was a quote that says that talks about a young lady who couldn't go to school for so long, and states that she stayed home for more than 2 months. She couldn't go to school. That's a clear loss in school time. Another individual complains about the fact that the individual experiencing the condition has to stop work completely and couldn't go to work because of the magnitude of the condition. And then in terms of productivity losses further, one of the respondents mentioned that I was called for an interview, but the boots they gave me, I couldn't wear them because of my leg. So this is someone who had a job opportunity and had to attend an interview, but then the nature of the work required him to put on some work gears, and because of his leg, he couldn't, and therefore had to lose that opportunity. And then there are also some findings that recently we've seen. I mean, it's always been there, but recent evidence sort of further highlights the issues around stigma as it relates to NTDs. We've seen evidence around fear and discrimination, where visible NTDs lead others to avoid contact or fear contagion amongst their colleagues or friends. There is evidence on shame and labeling, and sometimes there is evidence on marriage and work. So evidence from Tiwo et al. 2024, for example, where an individual reports that when I go to school, all the pupils do not want to get close to me. And another one mentioned that I did not feel comfortable to get close to my classmates anymore, where shame and labeling comes to play. And on marriage, a recent study in 2023, but mentions that my wife abandoned me and remarried just because I had this disease. So that's how far the disease consequences, the social and economic consequences can go, and therefore the need for us not to ignore them. We should also note that in our settings, in our cultural settings, we cannot ignore that NTD burden is actually not gender neutral. So in our settings, we typically see women who often absorb the unpaid caregiving work. They have to usually leave their productive activities and take care of the sick individual until they get healed. And that burden usually falls on the woman in the household. And if it's the woman in the household that gets sick, sometimes the children, if there's a younger girl, a woman in the household, other women in the household, then they have the responsibility to take care and absorb the indirect cost that comes with it. And that also suggests that the sigma intensity is usually also not gender neutral. In the quote we just saw, it's a man complaining about a woman, his wife leaving him because he had this condition. So the question that follows then is, how do these households cope with all of these issues? And I want to start by putting this in a broader context. So we think about social protection generally in our country as Ghana. And if you look at the National Social Protection Policy in 2015, it defines social protection as a range of actions carried out by the states and other parties in response to vulnerability and poverty. And if you look at the essential components of NTD, it has everything that should make an NTD patient or an individual experiencing NTD to qualify for social protection. For example, NTD patients need essential health care, including diagnosis, treatment, rehabilitation, and follow-up. NTD patients are most often people who encounter a disproportionate burden of poverty and vulnerability, and usually happens among rural households. There is disability and exclusion that comes with experiencing severe NTD. And then there is productivity inclusion, where disability and caregiving reduces the labor force participation of these NTD patients. So if you look at these components together, everything about NTDs make them clear social protection issues. Based on the definition of social protection as captured in our National Social Protection Strategy or policy. In fact, if you look at the social protection vision in that policy, it says that it wants to enhance access to essential healthcare, disability inclusion, productivity inclusion, and protection against poverty. And if you look at our disability reality, we have people who experience these conditions and have to suffer disability, income losses, stigma, schooling disruption, and household financial strain. So obviously there's a clear gap in the sense that we have services that are not readily available for these people, diagnostics not there, rehabilitation, as we have seen, the data is almost non-existent, and community outreach remains very weak, which means that our social protection systems in Ghana should also clearly acknowledge NTD patients as individuals whose coping strategies should be integrated in the country's social protection programs. In a recent study that we did in cases here as well, we actually saw different forms of coping mechanisms in the absence of these national social protection strategies. There are obviously other coping strategies that households usually use. And we've disaggregated this into three components: the formal protection systems, the community and social support systems. Sometimes they are informal systems, and then the household survival strategies. And we did this study in Ghana and Ethiopia. So in Ghana, for example, the formal systems include our National Health Insurance Scheme, which has benefits package that cover NTD patients. And then also a similar thing in Ethiopia. For community and social support, in Ghana, we had in-kind and cash donations that individuals reported to us, sometimes lending to cope with the economic burden of the disease. Community health committees sometimes contributing to help people to seek care and then eventually paying when they have the resources available. And then for household survivor, we have the use of household savings, some households reporting that they've had to borrow, some households reporting that they've had to reduce consumption within the household just to make money for the sick individual to seek care. And in other extreme cases, they've had to sell their assets to cope. So these are the kind of coping mechanisms that are currently being adopted by individuals in the country in the absence of broader social protection coverage. Finally, as I mentioned, I would just briefly talk about the economic case for investing in NTDs. Dr. Parry mentioned that we need to invest, but I want to, in addition to his call, mention that whatever money is spent on NTDs isn't just spending, it is actually an investment. It is an investment that has returns. So if you invest, you expect returns. If you just spend, then you probably don't expect any returns. And we should see it as an investment, not as spending. And recent evidence on Ghana actually provides compelling data to convince stakeholders to increase spending on NTDs. So, for example, the evidence suggests that if governments invests in NTDs towards elimination for the next 30 years, then it is possible to have to prevent almost 4.6 million new cases or cases that would have occurred in that 30 years. And this means that about 2.3 million health complications will also be prevented. Economic losses that would be averted in the next 30 years would amount to about 164 million US dollars. An economic benefit that will accrue to the country was valued to be around 366 million US dollars. In fact, if you look at the return on investment, it shows that if you combine, so this was done for three disease conditions: LF, onco, and leprosy. But if you combine these together, the return on investment is about 1.8 US dollars. What this means is that for every dollar that we spend, or sorry, for every dollar, I don't want to use the word spend, for every dollar we invest as a country, we can expect $1.8 back as return. And if you break this down into the specific conditions, the return on investment is even more interesting. So for conditions like leprosy, it goes all the way to 28. And for conditions like LF, it goes all the way to about 4.2 US dollars for every dollar that we spend. And in a scenario where they assume that the medications are donated and not funded by governments, the return on investment even shoots up more. So the combined return on investment for all the three conditions for every dollar spent, if we assume that the medications are donated, goes all the way to 7.2 US dollars. That's huge, which tells us that the real fiscal risk is not really the investment. It is allowing these avoidable disabilities and productivity losses to persist when we can actually invest and make returns, tangible returns from them. And if we choose not to invest and we choose not to do anything, the cost of inaction is actually also very compelling. So for example, we can expect that we'll lose about 38 million US dollars annually in economic losses from LF, onco, and leprosy in Ghana, which would amount to about 0.05% of our GDP as at 2020. And that means that we'll have about 256,000 people affected by at least one of these three conditions as modeled in the investment case. So what should we do as a country? What should be our goal? Our goal is not only to treat the disease, which is an important component, but it is to protect livelihoods, dignity, and human potential. And the things that needs to be done are varied. I think Dr. Parry mentioned a number of them, just to rehash a few of them. First is early detection, which is critical. Rehabilitation and psychosocial support is a major part, should be seen as a major part of the treatment and elimination efforts. Community systems and stigma reduction strategies needs to be enhanced. Decentralization is important for this early detection. Financial, social protection linkages are critical for people living with these NTDs or experiencing NTDs. And finally, and ultimately, WASH and prevention efforts needs to be scaled up. On this note, I thank you very much, and I'll pause here for discussions and questions.
Thank you very much, Dr. Navignon, for the very brilliant presentations. Do we have questions from Dr. Navignon? I see comments from Emmanuel agreeing with the catastrophic health expenditure that you highlighted. Somebody loves the fact that this webinar is introducing the social economic aspects of it. But Jake, a question from my end. You know, Ghana, we've tended to rely heavily on donor funding for NTD control activities, given the fiscal constraints within the global health space from funding agencies and the things of Donald Trump in the US.
Right.
What concrete financing mechanisms would you recommend to ensure that we have sustainable WASH and NTD services to help us in our goal towards our drive towards Vision 2030? Any thoughts?
Yes, thank you. So I think you said it right. So the current trends, and even from historical trends, we know that relying on donors is no more a sustainable option to finance any aspect of our health systems. And in the past few years, we've had governments also coming to the realization with, Ghana Beyond Aid chance, and recently our president committing to looking within to fill the gap left by the USAID issues that occurred. In terms of potential sources of financing, I think we have no other option. There are a couple of revenue generation options, and I think currently we are seeing improvements in revenue generation, especially through tackling efficiency issues that have persisted in our revenue generation efforts. So looking within, we need to consider improving efficiency, creating additional fiscal space within existing votes and budgets. Usual suspects, I mean, these days when you mention taxation as a source of revenue generation, people frown, but we don't have any option. If we want to look within and wean ourselves from donor funding that usually is not sustainable and unpredictable, then we have no choice but to look at how we can improve our revenue generation arrangements and be able to allocate some of this money also to these disease conditions. I think for NTD, to be specific, we need to push for line items or line budgets for some of these conditions. In fact, if you look at the national health accounts, there is no mention of NTD explicitly to say that this is how much we spent on NTDs. There's a mention on other disease conditions, which is a clear issue that we need to address. So I think advocacy will be key. Now we have some evidence, for example, this investment case, a clear evidence for advocacy or an advocacy piece. So I think it's important that we start pushing and advocating for NTDs to be put on the health budget and expenditure items so that we have clear allocations every year track what these monies are used for, make sure that they are used in an efficient way and achieving the targets that we set for ourselves.
Great answer. And I think that's an area that for Phillips and Co. and the country's ICC can champion. Dr. Nsiri Agana. Dr. Nsiri Agana, please, you have the floor. Kindly unmute, Dr. Agana. Otherwise, we'll have Priscilla.
Can
Okay,
you hear
Dr.
me now?
Agana. Yes, Dr. Agana, proceed.
Yes, thank you very much, Dr. Mwaku. I'm just following up on Novenyo's last statement about advocacy. Now, a lot of us have been educated on what has been presented so far, especially the students and the rest of us. But are there people on the platform, and I'm sure there are, who will package this information in a very clear way and present to the Parliament of Ghana and present to the President and present to whoever cabinet or whoever are concerned in this? I'm saying this because Abuja 2001, they promised that 15% of government budget for ECOWAS countries will go to health. Ghana met that only once since 2001. I think that was 2011 or so. So if, I mean, somebody mentioned about policies, I think it was in Novenyo, there are policies, but what is the outcome of those policies? So my suggestion is, please, GMA and whoever is involved, could we package some of these things and make cases, not only for NTDs, but all relevant areas, make specific cases, but NTDs is in question because they receive the least, if any, support locally. Could we package this and make clear presentations to the powers that be? Thank you very much.
Thank you very much, Senior Agana, and we acknowledge your contribution to these efforts in years gone by. I think I saw Dr. Patience's hand. If Patience is not on, then Dr. Kofi Sutherland. Dr. Sutherland, please unmute.
Yeah. Please, can you hear me?
Yes, we can.
Following up on what Dr. Agana said. You see, these NTDs have been going on for years. And KCCR, when they were working at Hunter West, Jomoro, Lemble area, I happened to be one of the people to work with them with Dr. Ohini, something. He later became the CEO for...
Professor Ohini, yes, correct.
Yes. What I realized is that we are not making very good use of the data that we have, and also not doing very well with some of the things that we've done. For example, in Hunter West, I did a hydrocell for a man whose scrotum was about the size of a football, and the wife had to run away from him because it has pulled the penile shaft in such a way that you could see just about 2 centimeters of it. But after the surgery, I still have the pictures. The man was relieved. He was able to marry again. These are things that we should actually package very well. Now, when we talk about Abuja Declaration, it is true that we budget all those things, but we should also look at the National Health Insurance, because the budget, what national health insurance gets is no small money. And how some of these can be used in prevention and in creative this thing. So we should engage them, the National Health Insurance Authority, the boss himself, and also look at ways of proper looking for money from corporate Ghana to support the program, because they have huge corporate social responsibilities. And if you look at the amount of monies that they spend on people, for example, recently when I was looking at Gold Board, what they were spending on people's surgery abroad, such monies will help to go a long way. For one person, will help to go along to support a lot of people in this country. Thank you.
Thank you very much, Dr. Kofi Bedus Sutherland, for that insightful contribution. And I note the comment from Solomon Anaya that World Vision, in collaboration with the Ghana Health Service and the country NTD champion, Reverend Dr. Joyce Ayi, will be making a case for NTDs at the corridors of power with ministers of states, parliament, and chief of staff in the coming weeks. So I think this is a direct reference to the comment from Dr. Agana. I don't see any other hand up, so I'll take the liberty and ask one last question of Dr. Nyovinyo. Dr. Nyovinyo, I noticed the household cost of NTDs was quite high. And I think I've read some work of yours which show that most of this is due to cost of transportation to seek care, because as you showed in earlier slides, most of the services are available at the regional hospital level and not at the primary health care level. So that means that they travel huge distances. I think we have some data from Atrimamponua which shows that people had to travel distances longer than 3 hours to access care.
Absolutely.
In your opinion, is there a case for the decentralization of care? Do you see that as a strategy to help mitigate these catastrophic household cost of NTDs?
Right. Thank you. Thanks for that very good question. Yeah, and that study actually that you referred to, some of the interesting findings that I think one of the key interesting findings was the role of transportation cost in shaping care-seeking decisions. So before that, we had, anecdotes about people going to traditional healers because of their beliefs or cultural demands, but we actually found out that some of those decisions were hugely influenced by costs, mostly transportation costs. And so they were trying to find an easy way out. So yeah, I think that decentralization is key. And in that study we did in Atrimamponua, we actually tested some, an intervention that tried the possibility of decentralizing care, and the evidence was quite positive. There are still questions about whether all, for example, some medications currently are not allowed at some levels, but there are certainly arrangements that can be made to ensure that we bring the care closer to the patients. Because if we believe and accept that this is a poverty disease, and those who are most at risk are those who live in deprived areas without much wash infrastructure, then we should also revise our approach to bring care closer. So I think that is possible. From the evidence we have from Atrimamponua, it seems to be a very feasible option to first reduce care and improve treatment outcomes for affected patients.
Great, thank you. And Dr. Opare, Senior Agungo is empathizing with you regarding the huge task you have ahead of you. And Philip Bonfe, thanks for the comments and commendation. I don't see any more hands up. I think we've done well. We've kept to time, and I would like to commend all the speakers for sticking to time and the participants for staying in, but also to thank the WHO Ghana, World Vision Ghana, the Ghana Medical Association, Konfuanoche, KCCRK and UST, and the speakers for their brilliant presentations. I have really enjoyed this, not because it's my line of work or because I'm moderating, but because we really have had very quality presentations, and that's we look forward to more of same. I've noted the commentary and requests from several persons on the meeting for us to have more sessions on NTDs, and so we'll take that up and do our best to meet the challenge. Also to Dr. Esiedu at the WHO Country Office for joining in. We'll take final comments from Professor Richard Phillips, Scientific Director at KCCR and Vice Chair for the Intra-Country Coordinating Committee on NTDs in Ghana. Professor Phillips.
Okay, thank you very much, Prof. Yawampema Mwakon, for giving me this opportunity. And I want to also add my voice in saying thank you to our brilliant facilitators, the World Vision International, Ghana Health Service, Kofanochi, GMA, WHO. There are so many that I need to say thank you to for helping making this possible. And above all, you all, the participants scattered all over the world, for participating. And it's also a way of advocating for NTDs. If we say it's neglected, then we need to have more of such sessions. And I see that reverberating in the comments box. So we've learned on integrating NTD control as a smart, cost-effective strategy. We are learning that joint health watch planning, targeting investments in endemic districts, and community-led behavior change as a good way forward. We are learning that NTDs in Ghana are not just medical problems, they are poverty-reinforcing traps, and that investing in NTDs delivers high returns, averts billions in economic losses, and protects human dignity. And that if we close the gap between policy and practice through decentralized care, rehabilitation, and social protection linkages, is both a moral imperative and a smart economic strategy. And so on that note, I want to say a final thank you to everyone and wish you a wonderful weekend. And we hope to meet again soon. Thank you very much.
Yes. So can I be heard?
Now you can.
Yes, Prof.
Okay, let's briefly. So thank you very much to everyone for participating. Good morning, good evening, good afternoon to all of you from around the world. We appreciate your custom and we look forward to seeing you at our next session on NTDs. Thank you. Enjoy your Friday evening and have a happy and blessed weekend. Bye-bye.
Bye. Thank you.
Bye.
Thank you. Bye.
Maybe panelists can stay on briefly. Once our participant drop off, we'll see. But thank you to Dr. Ajembrefo, GMA Ashanti Divisional Secretary, for hosting us. We really, really are grateful. Thank you, Dr. Solomon Jaban, for the hard work you put to this. Thank you, Team World Vision. Thank you, Dr. Pare. Thank you, Dr. Uso Entry, Dr. Novinho. I know making these presentations don't come easy, but we had such a huge audience that I'm sure it was worth your while. We are grateful. Have a good afternoon, everyone. So panelists, I thank you. And we'll catch you on the other side. Happy weekend.
Thank you so much, Prof, and all the other profs and colleagues.
Thank you. Thank you, Dr. Usuentri. Thank you, Dr. Opari. We know how busy you two are.
Yes.
So we appreciate your joining us. Ajahn Brefo, thank you. Jacob, as for you, our thank you will be over when we meet at the corner. So thank you, Prof. Phillips, and thank you, Team KCCR. Have a good weekend. Bye-bye.
Bye.
So, Prof, please, can I end the webinar?
Yes, please. Yes, please. Thank you, Ajahn.
Then I'm ending it. All right. Oh.